Good evening, all of you. Good evening, President Sir, and my dear eminent professors, dear senior registrars, and other colleagues. So, if a road is paved, it is suitable for walking or driving smoothly. So, today's topic is paving the path for future internists. We internists are all-rounders. Not like other specialists, we can diagnose any illnesses and we can manage any complications. And you might think obtaining MD and life is over. No, it's not the life. Once we obtain our MD, we might start seeing patients. We need to have interest on research. We need to have interest on particular topics. And we need to have authority on some topics. Because of that, we thought to make you more self-confident to have this exercise. And there will be 4 lectures by eminent professors. Once 4 lectures are over, we will unmute all of you so you all can ask questions from the professors. At the outset, let me thank Professor Senaka, Rajapakse, Professor Lekamwasam, Professor Thilak, Weerarathne, and Professor Thilak Jayalath for the busy schedules. Thank you, sir. Without much wasting time, may I invite our President, Dr. Ganaka Senarathne, to address you all first. Over to you, Ganaka.
Good evening to all of you. Thank you, Priyamali. Professor Senaka Rajapakse, Professor Sarath, Lekamwasam, Professor Thilak, Weerarathne, and Professor Thilak Jayalath. My dear sirs, I welcome all of you for this second session of SLCIM SR Forum. We are indeed honored by your presence today, and indeed it's an inspiration for all of us. And I welcome all my dear SRs who are joining virtually from every training center of Sri Lanka. And this is the second session of SLCIM SR Forum. And as you know, SLCIM SR Forum was established in order to help our senior registrars for their professional development. So the college believes that the forum would help our SRs to become competent, confident, and compassionate internists in near future who will be providing holistic and humane care for Sri Lankan nation as well as whole wide world. So I make this opportunity to thank our Honorable Treasurer, Dr. Priyamali Jayasekara, who passionately lead this project with a lot of energy and hope. Thank you, Priyamali. And dear SRs, I trust today's session would add a lot of things for you to think and would add a lot of things to your profession as well. Without taking much time, may I hand over the stage to Priyamali to conduct this very important session. Pave the path for future internists. Over to you, Priyamali.
Thank you, Ganaka. And you know, there are people who do not get introduction. So all our 4 speakers, they do not actually need introduction. So may I invite our first speaker, Professor Senaka Rajapakse, to talk on developing a research interest. Over to you, sir.
Thank you, Priyamali and Ganaka, for your kind introduction and for inviting me to speak. So anyway, it's a privilege to be invited to speak at this forum. I think it's an important thing for senior registrars to have some motivation to do various things, and the 4 talks you've lined up today are all very interesting, relevant to the trainees. I've talked about this research interesting on many occasions, and in the next 20 minutes or so, I think I'll try to give an outline and give some fairly solid guidance to the trainees and to the SRs and to others who are interested in developing a research interest, because most of the time what we find is that people are not very motivated to do research or to engage in good quality research, and most of the time people do it for the sake of doing it because they have to. So what I'm trying to do is to motivate you to make it more interesting and make people want to do research because it's a part of their job. And I think as an as internal medicine specialist, it's quite important to have a wide range of interests in academic as well as clinical stuff. Somebody is raising a hand. I wonder whether she can't hear. Premali, the sound is okay, right?
Yes, sir, can hear very well, but if they want, they can put their question to chat box or wait at the end. We can unmute all of them.
Right. I was just wondering whether somebody can't hear. Anyway, to move on. So the first question is, why do we do research? And this is a question that most of the trainees, I'm sure, would be asking. There are several reasons why people do research. First of all, it is believed that research enhances knowledge. And that's probably the most important reason for doing research. And that's why most of the research is done, because research enhances knowledge and knowledge changes clinical practice. So that's a good reason. There is also the belief that research is important. So it's necessary to do research, and therefore we should do it because it's an important thing to do. Sometimes not necessarily because it has an impact or an outcome, but because it's important to do research. It's just a belief that that's there. Institutions like their staff members to do research because it enhances the institutional profile. On the ranking scales for many universities, research is an important component which gives them marks and points to rate them high on the ranking scale. This is useful particularly for foreign universities where ranking is all important. In our country, it's less important because admissions to universities and institutions of higher education are not based on the ranking of the university, but other factors which we all know. Then, as an individual, your academic credibility is also based on research. In the current context, especially in other universities and other institutions, if you haven't done any research, then you are not considered to be an academic. And hopefully that culture will develop here as well, where people will recognize the importance of being academically credible by having a good research output. Promotions in universities are linked to your research output, or at least should be. This is not always the case, however. And then it is generally considered that training programs are superior if they have a component of research, and that's why the PGIM makes it mandatory for people to do a research component, because it is believed that it enhances the quality of the training program. That is again true to some extent, because the Sri Lanka qualifications framework, which grades the degree of MD and board certification as a level 12 qualification, that is the highest qualification that's available, and it's equivalent to a PhD. It is graded so because there is a research component. So I've had arguments with senior registrars who say that why should we do research? We are going to be practicing clinicians, and practicing clinicians don't need to do research. That is obviously not the case, because going back to the first bullet, research enhances knowledge, and research and such knowledge will enhance the quality of care that we deliver to our patients. So we can't expect others to do research for us and for us to just implement the findings. It is part of our responsibility to contribute to the generation of knowledge. Remuneration is also linked to research output, and that's a very base reason to do research, but it is an important one nonetheless. Even our research allowance is paid if we do some research, and our salaries also increase. And in many countries, professors' careers are dependent, and the amount of money they get paid is directly proportionate to the amount of research they do. But in reality, many of us find it hard to do research. If you are starting up research, it's sort of a great big thing out there which you feel very wary of. It is because we have many obstacles. So the first thing is that we are unfamiliar with research methodology, and therefore we don't really know how to set about it and get involved in research. We are also unfamiliar with the tools required for research. Then we find it hard to get involved in multidisciplinary research. It's a difficult for a person to do research just in one discipline. You often need to involve experts in other areas. There are also people who tell us that research is very difficult and research should be controlled, and people place a lot of obstacles in the way of those who want to do some genuine research. And this I see quite often when we go on the forums with the Sri Lanka College of Internal Medicine, where people often would like to do, there's a lot of enthusiasm to do research, but you can see that certain individuals find it difficult because of these obstacles that are faced. And then there are the experts who are generally not real experts, because as I always say, those who actually do research have very little time to place controls and governance on other people to do research, because they are already busy doing research themselves. You find that there are a lot of experts who say that they are the ones who are doing most of the research, but if you look at their research profiles, you find that they are mostly self-proclaimed and they are not the true experts. Then there is this belief that it is difficult to find funding. That is true to an extent. It is also not true to an extent. The support we have for managing research projects is very limited. That, of course, is very true. We find that we'll be printing the questionnaire out ourselves. We'll be walking to the ethics committee to submit the proposal ourselves. And in other countries, of course, there are people to do all these things, and it's much easier. And of course, all of us have a limitation of time. We do this in the middle of doing a government job, and most of the time, a lot of private practice also on the side, which takes up a fair amount of time. So these are all obstacles, and this is why we find it difficult to do research. What I'm trying to do in the next few minutes is to tell you how you can overcome some of these barriers. Some of these barriers are very easy to overcome. For example, the restrictions placed on you by people who proclaim themselves to be experts and demotivate you to do research by saying it's all very difficult and you have to be a real expert to do these things, just ignore them. So that part is easy. The rest is a little more difficult, but let's move on and go through a few things which might be helpful. How do we choose what to study? In the case of senior registrars, often there is a mandatory research project as a part of your training. And there is a deadline. Often this deadline is ignored, and then you suddenly realize that there is a deadline. And if you don't do it on time, your board certification is going to get delayed. And therefore, you run about trying to find a suitable focus area which has not been done before, where you can do some research and get a research report at the very least, or a publication if you are lucky. So that's a fairly good reason to do research, but it's not one of the best reasons. Then you might have a supervisor who might be your consultant, and he has a area of interest. He's interested in doing some research on a particular topic, and then he may be a gastroenterologist or a neurologist or somebody like that with an interest, and then you fit into his requirements and try to do some research in his area. Then there might be some funding available for a specific area, and most of the research in this part of the world is driven by funds which are provided by overseas funding agencies, and by and large they tell you what to do. It's not ideal, but then obviously you have to be opportunistic in such things. Sometimes there is an industry driven idea. There's a drug company which is trying to sponsor a research project, and they are giving some funding and they're willing to run the project, and people get involved and do some research there. Probably the most important reason for doing research is that there is an area of key importance and answers are needed. And this is the most relevant and most important form of research that we could do. For example, there is COVID. We are looking for a cure for COVID, and let's look for a cure for COVID and do some research on it. So there's an area of key importance which is relevant to the country, and we want to do some research in that area. That's the best reason to do research. Of course, the really lucky people can do what is called blue sky research. And blue sky research is where you ask a very abstract question which has absolutely no relevance to what you're doing or practice, or it won't change any practice. It stems from the principle, you ask the question, why is the sky blue? It doesn't matter why the sky blue is, it is just blue. And it's unlikely to change anything if you find out the reason for why it's blue. But nonetheless, you want to find out why it's blue. So, ladies and gentlemen, the fact is that for medics, for internal medicine physicians, what matters most to us is providing proper patient care. And this slide gives an overview of the various different areas you can study with regard, which will have an impact on patient care. But the top, probably the most important, is clinical research with a direct impact, something which will be beneficial to the patient directly by researching on how diseases occur, how therapeutics can change the outcome of diseases, etc. Then, of course, drug development and development of investigations is an important area, and it can be linked up to basic sciences research, where you understand the pathophysiology and mechanisms of disease in order to develop various drugs and develop various investigations which will help you in your clinical practice. The other three, outcomes and audit, are important, useful for clinicians as well. But systems research and communities research are basically left to other people, not in the field of internal medicine, but usually community physicians and medical administrators. But we can all get involved in all these research, these different types of research. When it comes to when it comes to different illnesses, obviously we focus primarily on a clinical illness, and these are the various areas which can be where you can identify a suitable research project. So you can think of looking at vaccine development and prevention of diseases, community level prevention, investigations and scoring systems which will lead to rapid early diagnosis is a very, very welcome area in clinical practice. Then things which will predict disease progression. For example, dengue, you want to know whether there's something which can predict which patients will develop dengue shock, and identification obviously of risk factors. These are all areas, if you think about it, you can find a question that has not been answered, which you could seek to answer. Then, of course, understanding pathophysiology is important in order to develop specific therapies and critical interventions, and sometimes investigations which will help to diagnose things as well. So it can either be clinical research where you work with a basic sciences investigator and find out triggers or points where you can develop specific therapies and critical interventions. And in the end, it all should boil down to the impact it has on treating clinical illness. Then, of course, there is quality and safety research, which is equally important. So what I would say is, when you want to find a topic, if you think around these areas, it's very easy to find a suitable area which you can do some research on. And then, of course, having identified the thing that you want to study, you need to be very clear about the study design and choose the right study design in order to get the best results from your research. So if you are investing time and resources on a research project, it is quite important that you choose the right study design, because if you don't choose the right study design, it is a waste of time and of resources. So ranging from RED, which is a case report, which is the poorest form of evidence and probably things you shouldn't waste much time on, you move up the ladder onto the best quality research, which is experimental research, which involves things like controlled trials. It's often difficult to do a controlled trial. It needs a lot of resources and a lot of experience. But in between, you can do good descriptive studies, cross-sectional studies, and you can do case control studies, which are intermediate quality, and observational analytical studies, such as cohort studies and case control studies, are generally doable for most people without the use of a great amount of resources. The strength of evidence is obviously greater as you go towards the green. And synthesizing this evidence into meta-analysis and systematic reviews is another thing that many of us can do in our spare time. It's fairly easy if you have the right tools and the right guidance. If you are looking for a good publication, a good way to start is to do a meta-analysis. It's not that difficult if you use the right tools and you gain a little bit of training in it. Of course, the starting point, once you have decided that you want to do research in a particular area and that you want to do it using a particular study design, the most important thing is to write a good research proposal. So this is an important slide because it gives you the outline of what you should do when you write a research proposal and the different sections that you must include if your research proposal is going to be successful. You first ask the question, what is the title of my project? What do I want to call it? And that is what is named as the title. Then the next question is, can I summarize my proposal? Because the person reading the research proposal will want to look at a summary and say whether it's a worthwhile thing to read. So it's very important, because if the proposal summary is good, then he is going to read further, and that is known as the summary. Then what is currently known of this topic? That's an outline, that is your background information. What is not known, and that is the research question, is the hypothesis. Then why should this research question be answered? And that is the justification. What outcomes are expected from the study? And that is the objectives. How will the research question be answered? Is the methodology. What are the measurements? And that is the variables. What approvals do I need? That is your ethics committee, your hospital advisory committee, etc. How will I analyze the report, the results? And that is the analysis and statistics. What is required for the study are the resources and funds. What are my references is the bibliography. What are the questionnaires and data pro formas that I need to add to the research proposal? And those are the supplementary material. So ladies and gentlemen, this is what these are the different components of a good research proposal. And if they are done properly, this will convince the funding agency or the research and hiring risk committee which is approving this research, or your supervisor, to say this is a good project and let us go ahead and do it. Now there are a lot of tools that you need. First of all, you need a good reference manager, and there is EndNote, which is commercial, and Mendeley, which is free, which helps you to organize your references together. There are other tools that are useful. Review Manager or RevMan is a free tool provided by the Cochrane database, which helps you to design meta-analysis and systematic reviews. Then you must have access to some bibliographic databases, which will provide you with background information. Statistical software is useful. So SPSS is what we commonly use, but there are simpler forms of software which you can access, which are free of charge. You need a good graphing software, produce fancy graphs which are used to disseminate your information. If you go for more advanced things like geographical mapping software and devices to do GIS mapping, very useful if you are familiar with it. The most important tool that you need obviously is common sense, because without that you cannot do anything. Now, a word about the bibliographic databases or citation indices. There are many different bibliographic databases. We are all familiar with the ISI Web of Science or Thomson Reuters Web of Science, which is a science citation index. Then there's PubMed and Medline. There's Embase, Scopus, which you have all heard about. And there is the Cochrane database. But there are also other sources of information in the world, which we sometimes ignore. There's the Lilacs database, which is from Latin American research. There's the Chinese science citation database. There's a whole world out there in China. And then there's Google Scholar and institutional repository. So when you want to find out background information on your proposed research project, you would need to go wider than just doing a PubMed search. Funding is always thought to be very difficult, but in practice is not so difficult. A lot of good research can be done with minimal funding. The industry may provide some funding. There are often grants from the colleges, and you will often realize that these grants that are offered by the colleges are not utilized. People don't apply. National Science Foundation, NRC, a little more difficult to receive funding from them, but again, doable if you have the right research proposal and if you have a little bit of experience gained. Universities provide quite a bit of funding if you look for it, and there are obviously international funding agencies. A little more difficult to get funding from them. The quality of your proposals have to be better, but it is worth trying once you have developed some experience in research. It is important to have teams to do research. You cannot do them alone. Good quality research now usually have multiple authors and multiple research collaborators. University academics are obviously more geared towards research, but do not think that that is always the case. There are many very good researchers who have not held academic posts in universities. You have to collaborate with other hospitals, with research institutes, overseas collaborators, experts in different fields, and of course, identify research students who might be interested in getting involved in some research. Ethics and approvals are very important, and don't ignore them at all. They are essential for publication. There are several ethics committees which are recognized by the Ministry of Health, so it is better to apply to one of them. Institutional approval from the hospital or institute you're working in is also important, but very important also is to obtain permission from your collaborators and co-investigators. For clinical trials, there is the Clinical Trials Evaluation Committee of the NMRA, and there is the Sri Lanka Clinical Trials Registry. Plagiarism is another thing you must avoid like the plague. Plagiarism is the practice of taking someone else's work or ideas and passing them off as one's own. Avoid it by or at all cost, because it will blacklist you. So it's very easy to cut and paste something from another document or a research paper, but you can get into a lot of trouble. There is a difference between plagiarism and similarity. Similarity is just where what you have written is similar to something is written by somebody else, and it may not necessarily be intentional copying. But plagiarism is where you falsely proclaim that somebody else's work is your own. So one way of avoiding similarity is to paraphrase. If you have to quote the findings of another researcher, you need to rephrase it in language which is different. And always remember to cite and acknowledge if you are using somebody else's work, and discuss the findings of others as relevant to your work. Disseminating of findings is the final step once you have done your research and got all the data together, and reach for the stars. Try to go internationally or to good local conferences, and always try to disseminate your findings through an original paper rather than stopping at just an abstract. So to conclude, doing good research is not easy, but it is possible if you have the right tools, the right training, and the right motivation. Don't be discouraged by those who will try to discourage you. There are plenty of such people, and you will notice that they are the people who have not done any research themselves. Arm yourself with the right tools, collaborate and build teams. Working together will give you better quality research. Look for funds, there's plenty of them out there, and remember to disseminate your findings. Thank you very much.
Thank you very much, sir, for that motivational talk. So we'll invite the second speaker, that is Professor Sarath Lekamwasam. He will talk to us on standing on your feet, building self-confidence.
Hello, everybody. First of all, let me thank the Sri Lankan College of Internal Medicine for giving me this opportunity. And to be on the safe side, I thought I'll record my presentation and send it beforehand due to the prevalent situation in the country and many uncertainties. When you look at the usual work of a physician, and you can find that mostly the work is routine, but of course it can be challenging at times. And a physician should be aware of the emergence of new diseases, and actually it's a physician who will come across these diseases in the first place. And also he should be aware of what I call the change in disease pattern, and both of which, of course, we have witnessed quite adequately during the pandemic, COVID-19 pandemic, as a new disease, and it kept on changing its disease pattern, and with the emergence of new strains. And also, physicians should be aware of what's called new investigations which are added in order to help physician making the final diagnosis. New treatment options, new management strategies, and they should be very well aware of economic and social aspects of patient care as well. And also the work of a physician can be quite competitive and also brings a high level of stress. With all that we have seen during the last several years, globally as well as locally, the phenomenon what is called fragmentation of patient care, fragmentation of health care. And this is where the patient who requires a treatment by multidisciplinary team or many specialties, and then patients who are not getting adequate treatment because these patients are not referred adequately between specialties. But there are many reasons why there's a fragmentation of healthcare, and one of those is what's called emergence of specializations. And with the introduction of more and more subspecialties into the clinical patient in medicine, and then this fragmentation starts occurring. And also like what's called lack of shared responsibility. And shared responsibility is a key requirement in what's called the multidisciplinary management patient care. But what we have seen mostly in the Sri Lankan scenario is not multidisciplinary care. It's the individual specialties are taking decisions on their own and not communicating adequately with the team. That's not very satisfactory situation. And also when the caregivers has little personal contact with the colleagues outside. And also poor referral systems and not giving adequate information in the referrals when the patients are referred to another person. And lack of central electronic health records, and prevent people accessing information. Healthcare fragmentation can be quite costly. And this particular study published in 2017 shows that the patients with the most fragmented care had nearly twice as many radiology and other diagnostic tests, and when compared with patients with the least fragmented care. And this was true across all patient groups, stratified by number of chronic diseases. And among patients with more than 5 chronic diseases, and those with the least fragmented care, had, let's say, 258 tests per 100 patients, and that compared to the people who had the most fragmented care, a number 542 tests per 100, so almost like a double. So you can see that's become a very costly business. Fragmentation become a very costly thing for healthcare systems. These two clinical scenarios I have taken, these are real clinical scenarios, just to highlight how this fragmentation occurs. A 78-year-old man with hypertension and dyslipidemia, he was on losartan and atorvastatin. Fasting glucose was 520 with a very well-controlled cholesterol and LDL. His serum creatinine about 1.5, and this is why the physician got excited about it. Normal hemoglobin and indices. He had a sensory motor type peripheral neuropathy for 3 years, non-progressive, just confined to the below ankles. And the physician referred this patient to neurologist and the nephrologist, both on the same day. The neurologist did a nerve conduction study, confirmed the patient has got a sensory motor type of neuropathy, and for some unknown reason, referred this patient to endocrine. This patient so ended up with 3 specialties. On return to physician 6 months later, of course, he was on telmisartan. He was on many medication, atorvastatin, calcium carbonate, 1-alpha, omega-3 fatty acids, and 2 other medications, 2 other vitamins. And his serum creatinine has crept out to 1.7. The second case scenario is a 75-year-old woman with a difficulty in breathing over 1 month, no fever, cough. She had a breast cancer for 2 years. The chest radiograph on presentation, the emergency care. There's extensive alveolar shadows, and she had difficulty in breathing. And she was sent to ICU by the ETCT. Excuse me. She was started on non-invasive ventilation and hepatitis, and the day 2, clarithromycin was added, and the day 3, doxycycline was added. Ultrasound abdomen showed that deposits in the liver or some myelocitis. And then we decided on tender-loving care and the palliation, discussed with the family members, and the decision was made to send her to a medical ward and the family to be with her in the remaining days. Meanwhile, blood culture, which has been sent sometime ago, through a staff. And then sensitive progressive tazobactam was insisted starting on progressive tazobactam and in order to control this infection. This third case scenario is regarding what is called the self-confidence on the clinician, both their clinical judgment. This is a story of a 20-year-old woman, a sister of a staff nurse from Sarath. She came with abdominal pain and anorexia. There's no loss of weight or fever. And she was found to have ascites during the clinical examination, and which turned out to be an exudate. A TB PCR was not available at that time, so it's about 8 years ago. MAN2 was positive. ESR was high, and the hemoglobin was 10. Chest radiograph was normal. Ultrasound abdomen and the CT normal in sense had ascites, but again failed to demonstrate anything more than that. The tentative diagnosis of extrapulmonary tuberculosis was made, and then TB medication was started. And then 1 month later, there was no change in the clinical condition, and also there was no appreciable weight gain. She visited one of her relatives in Ragam area, then got abdominal pain during the night, and she was admitted to a North Colombo Teaching Hospital and underwent ultrasound scan abdomen on the next day, and they found an intra-abdominal mass and around the right ovary. and they suspect ovarian malignancy. And she referred to Cancer Institute, Markham. So the sister came running back to me and said something of this nature has happened, and she's going to have a exploratory laparoscopy. And then about 3-4 days later, again I found her seated in my ward when I went to the ward in the morning. And then I inquired and then said that they did laparotomy and then found that TB, peritonitis all over, with the momentum which is stuck into the ovarian area, and that was that mimic ovarian malignancy in the ultrasound scan at 2 months, so it was tuberculosis. The self-confidence on clinical judgment, the lack of self-confidence in the physician part lead to what's called over-investigate. They tend to over-investigate patients. And also over-treatment, definitely. And they try to cover that problem with the self-confidence part with over-investigating and over-treating the patient. And of course, studies have shown that, that type of thing, that the lack of self-confidence lead to longer hospital stay in patients and also overcrowding of wards. But I'm going to talk about only first two. The history and examination is the luxury of the physician. And all the physician should be able to get relevant information in the history, and also relevant information in the examination. And also how you process that information. The differential diagnosis, a reasonable differential diagnosis to be considered. It's called clinical reasoning, this concept of clinical reasoning coming here. And then the choosing investigations, using common sense, and also appropriate management plan. Now, I'm just going to talk about a few investigations, but what I say here is not applicable for those investigations done to help the management. For example, liver, we do liver function and renal function before prescribing certain medications. I'm not talking about them. And also, I'm not talking about the investigation done for the prognostication, like immune markers in malignancies. But I'm particularly talking about the investigation which are done to either confirm the diagnosis or exclude the diagnosis. So in order to arrive at the final diagnosis, a particular investigation should either help to confirm the diagnosis or exclude the diagnosis. If that doesn't happen with that investigation, and perhaps don't do it, because it's only a really waste of time and waste of money. This is when you try to achieve the final diagnosis, and you have got what is called the probability scale. And at the bottom, you have got the probability of 0, that is the probability of that particular diagnosis is 0. And also on the top, you get the probability of that diagnosis, that's 100%. So the people who are in the lowest range, that is the area, they don't need investigation because they can be just discharged from the hospital without further investigations. And also people in the top area, and also you can offer treatment because you have made the diagnosis certain, and then as a result of that, you can offer treatment. So it's only the people who are in the middle area need investigations. So when you do investigations, and then the investigations, that particular investigation should either take you more to the top layer or the bottom layer. And how much distance that you can travel with that particular investigation is that particular ability of that investigation is entirely dependent on what is called the likelihood ratio of that test. The likelihood ratio can be either positive, and then you go up, or likelihood ratio can be negative, so that go down. But if that particular investigation is going to bring you back to the same area, and perhaps don't do it because it's not going to help you in any way. Now, these likelihood ratios have been worked out by some people. People have estimated them. When you say the positive likelihood ratio, there's a probability of having the disease and moving up. And the negative likelihood ratio is a probability of not having the disease, and then you are moving downwards. And for this one example, the serum ferritin and the iron deficiency anemia. You can see when the serum ferritin is less than 15 milligram per deciliter, then it is associated with the likelihood ratio nearly 51 or 52. But if that serum ferritin is found in the range of, let's say, 15 to 24, then the likelihood ratio drops. because then it's a less likely we find anemia. And you can see that, serum ferritin become more and more, and then become greater and greater, and then likelihood ratios are dropping. So this is, let's say, if before the test, a particular test, your probability of the diagnosis is only, let's say, 20%. And this particular test has let's say, 10 likelihood ratio. And then that particular test, if it becomes positive, would take you to your probability after the test would be 70%. You can say that from 20% goes to about 70%. And you would say that if it is 70% probability, I'm happy to treat this patient. Right? So that particular investigation would help you to reach that level. So that is how these probabilities work in your mind. Now, these are the examples of the common diseases and the test and likelihood ratios. I've taken that from the American College of Physicians and one of their presentations. For example, let's say acute pulmonary embolism and pulmonary CT angiography. It's positive, and what's the likelihood ratio of the pulmonary embolism with that positive test? And if it is negative, then what is the likelihood ratio? So all these investigations have got what's called likelihood ratios, either positive and negative, and the clinician should be aware that how you use this information. That's about the investigation. Let's look at this clinical scenario. This is again about a patient that we have been managing for a long time. This is a 25-year-old girl with a non-specific chest pain for 3 months duration. This is actually very long, very nice history. And in fact, what was happened that she got married recently, and the husband went overseas soon after wedding. And then she was getting admitted to local hospital with a non-specific chest pain. And everybody thought that, she's anxious and she's not very happy about it, because has been leaving her, soon after wedding. And then she went to the hospital. And then if you say that, if you get a 25-year-old girl with a non-specific chest pain, and your probability of a cardiac disease in that patient is pretty low. But then the examination at the bedside, if you spend some time, and then you found that patient has ejection systolic murmur, and then at the left sternal edge, and also that you have got evidence of right ventricular hypertrophy in the sense of parasternal heave and loud P2. And then probability of this being the patient's having cardiac disease suddenly jumped to about 90%. Because you can say, well, until further, this is a cardiac disease. So just because at the bedside you found, without any cost, you found that patient have ejection systolic murmur in the left sternal ridge, the parasternal heave and the loud P2, and then from that possibility of 0.1 or almost like a 0, you jump to about 90%. And then no investigation can match that. For example, let's say if you had to draw a line from 0.1 to, let's say, 90%, and then the likelihood ratio of that particular information is unimaginable. You cannot estimate really. So this is why that the clinician, the physician cannot forget about the history and cannot forget about the examination. So the detailed history and a detailed examination and getting this investigate this information is vital and crucial for a physician to make a diagnosis. So investigation can help them, but then you should not rely too much on investigations in that sense. About the prescribing, few words about the prescribing as well. And the people, clinician, physicians should have a discipline in prescribing and not try to cover everything with the except pill. We call it pill for each ill. So every time patient says something, you write a medication for that. So you should have discipline in prescribing. And also it should be logical and cost effective. Lesser number of medications in the prescription make it much easier for everybody, for the patients, for the caregivers, people who are paying for it, and everything that become much nicer. So avoid what's called polypharmacy. And also there should be the physician should use some policy in antibiotic use, and not that every patient with a fever is not getting meropenem or ceftaxime. There should be a policy in antibiotic use. And also you can follow guidelines in using costly drugs. And the two drugs which are thoroughly misused in my opinion is the intravenous albumin and intravenous immunoglobulin. And these particular costly drugs are thoroughly misused in wards. So there should be a common sense in prescribing. When I was let's say medical student or junior medical officer, and we entirely depend on the experience. So experience of clinician. If clinician says start this patient on penicillin, and luckily we had only very few antibiotics at that time, and we start penicillin. That's because he says, well, my experience is that this patient will get better with penicillin. And you're not going to question that. There's no way you can question that. And then we came what's called evidence-based medicine, and then you take the experience out of this equation and then you rely on evidence. But now we say again, we are trying to get back on this. Now there are what I call expectations of patients, which we highlight in post-graduate examinations. And then what do patients, what expectation do they have? And out of that particular encounter with the patient and with the patient with the doctor. And then economic considerations very much in the picture. So now, of course, you have got a combination of experience, evidence coming from research, and then expectations, and then economy. So all these are taken into consideration together and making decisions on prescribing. So in my short presentation, I want to highlight that the physician should be in the driving seat. And then you can see that when you're working, you get information from many of your colleagues. Let's say maybe about 2 or 3 colleagues are involved with that. So there's a lot of information coming from you. And also there's information coming from investigations. So how you handle that in information and how you handle that opinion from your colleagues, and then remain in the driving seat in that particular patient care and the management plan is something that people should develop. That particular skill and should be developed. And this is what's called integration of management, integration of patient care. Otherwise, the whole thing gets fragmented, and then people start managing these patients on their own way, and they make their decision in isolation. So you should not allow that happen, and you should try to integrate that patient care and remain in the driving seat. And always rely on clinical information. Do not disregard clinical information. That is a luxury that you have at the bedside. Every day at the bedside, you get plenty of clinical information. No cost. And also judicious use of investigation. Do not use investigation just because that available in the hospital, or just because you can just do it and see, and don't do that in that way. You choose investigations so that you will reach the diagnosis. So you can make a decision on the final diagnosis, and also have some discipline in prescribing. So that will give you self-confidence and to be a good clinician, a good physician. And with that, you certainly can thrive in your discipline, in your chosen area, and be a good doctor. And also a cost-effective management of patients, and also with good clinical outcome. Thank you very much for the opportunity given to me to speak in this forum. And also, if there are questions, I'm very happy to join at the end. Thank you.
Thank you very much, sir, for that thought-provoking speech. So we'll go to the last speech of the day, that is Achieving for the Girls. May I invite Professor Thilak Jayalath to deliver his speech. Over to you, sir.
Thank you, Premali. Can you hear me clearly?
Yes, sir.
Let me thank Premali and Ganaka for inviting me to join this webinar. And Premali wanted me to speak on achieving for the goals. When I asked Premali, what should I talk on this topic actually? Premali wanted me to speak mainly on obtaining further qualifications. Now, my task is easy now. My previous 3 speakers, they have made my life easy, and they have covered most of the areas that I was planning to speak, but I will only speak on how to obtain further qualifications. Now, these SRs in this webinar, who are attending this webinar, they all have MD. So how to obtain further qualification, that's what I'm going to discuss. And why should we have these more qualifications like MD, MRCP, MD, FRCP? There are many advantages of having more qualifications. One thing is you are recognized. Now, when you have MD, MRCP, FRCP, you feel that you are internationally recognized. And also you get more opportunities in terms of job opportunities. Like we know that those who are with MRCP, they have a higher chance of getting a job in countries like Middle East, countries like Singapore. There are better opportunities for jobs. So I think it's always good to have this qualification in addition to MD. And when you look at the university system, when you apply for promotions, it's always good to have FRCP, FACP fellowships. You can claim for more points. So there are opportunities and advantages of having these qualifications, further qualifications. Now I'm going to discuss two areas mainly, that is UK qualifications and US qualifications. When you discuss about UK qualifications, we are mainly going to discuss about MRCP and FRCP. And this MRCP, I'm sure all these attendees in this webinar, you are familiar with this MRCP setup. And fortunately now you can, I think you are in a good position now. You can sit for this MRCP PACES now in Sri Lanka. About, I think, few years back, we started this program in Sri Lanka. So you can sit for PACES after a theory paper. So there are advantages of sitting here. You are in a form environment. You are much comfortable. So you can do your PACES exam here. The other advantage is once you get MRCP here, and when you go for this overseas training, you can concentrate more on your work and you don't need to spend your time to prepare for this exam. So that's one advantage of doing this exam here. And when I look at the MRCP exam as an examiner, I can tell you that our candidates, Sri Lankan candidates, they don't do well in station 2 and 4. And these are the stations testing your communication skills. So in this webinar, I want to tell my colleagues, those who are going to sit for these spaces in the future, please concentrate on this point, because we are not sometimes good in communication. So please concentrate more on this point about communication and improve your communication skills, mainly to, it will help you to pass this exam easily. Station 2 and 4, those are the two important stations in the PACES where your knowledge will be tested on communication. Then about MRCP, not like our time. Now the MRCP, once you get MRCP UK, you can even get more MRCPs like MRCP Internal Medicine, MRCP Geriatrics, MRCP Endocrine. And these are the new developments in the recent past. And I was told that those who are doing internal medicine, one easy way of getting MRCP, the further qualification is the acute medicine. So you can, those who are with MRCP UK, you can try for MRCP acute medicine. But other fields like endocrine and rheumatology, those are a bit difficult, but those who are with a good knowledge certainly can go for those qualifications as well. The cost is about £800. So it's a theory paper. It's about 6 hours of theory, and there are no clinical, there is no clinical component. So you can sit for this specialty certificate depending on your interest. So that's something you can think of later once you with MRCP UK. Then with MRCP, the other advantage is you can apply for fellowships. You can get FRCP London, then Edinburgh, and also Glasgow. All these 3 colleges, you can have 3 fellowships. So that's one advantage, as I said earlier at the outset, that having FRCP can be useful, especially for those who are in university system. You can claim marks for your promotion. And these rules and regulations are becoming less strict now. Now, there was a time that with MRCP, the candidates, they had to at least wait for 5 years. Now they are becoming less strict, and you can even apply for FRCP even after 2 years with MRCP. And myself and Senaka, we are the regional advisors in the Edinburgh College. So I'm basically the regional advisor outside Colombo. Senaka is for Colombo area. So whenever you want, we are happy to help you to get your fellowship after MRCP. Then a few things about getting fellowship. Actually, I have been helping many of our colleagues to get these fellowships. When I tried to send when I tried to fill these applications, I found that some of our colleagues, those who are with MRCP, their CV is not very strong. Few things I want to stress here. In the CV, you have to mention about your teaching component, your commitment to teaching, how much you teach medical students and then the registrars, and that has to be addressed. So think about these areas if you are planning to apply for fellowships. And also your commitment to the society, what you are doing to society to improve the hospital setup. So those things are important in your CV. And if you are planning to apply for fellowships, think about these things after MRCP when you are planning to apply for fellowships. Then I think that's about the MRCP and the fellowships from UK. The other important qualification is the FACP given by American College of Internal Medicine, ACP. And when you look at the membership fees globally, this American College Fellowship, the membership is not very expensive. It's about $110 annually, much cheaper than the UK college's annual fee. So by spending about $110, you can get the membership, and you have to wait for 2 years if you're going to apply through the normal pathway. But if you're really good in research, you can apply direct even. I know there are some members in our college with direct who they were able to get the fellowship within few months. So you don't need to wait for 2 years like in the standard way. So think about getting this FACP, and the important point is you need to have the membership. So I want to advise these SRs in this webinar, please get your membership from the American College of Physicians, and then in 2 years' time, you will be eligible to get this FACP, which is a prestigious fellowship. And there are many other organizations like European Society of Cardiology. They also give fellowships, but there again, you need to have this important contribution to the cardiology field. So those who are in the internal medicine with interest in cardiology, you can apply for this with some research work, apply to this fellowship in the ESC. As I think Thilak, he mentioned about diplomas. So you can apply for diplomas. There are many diplomas conducted by the Royal College. So there are many opportunities. You can apply, even diabetes, and then acute medicine. So you can think about these diplomas in addition to MRCP, FRCP, FACP. And these diplomas can be very useful in your practice later on once you come back to Sri Lanka. So those are the few things that I want to discuss under the topic that Premal gave to me on achieving further goals, mainly to get more qualifications. And I think the time is almost now 9 o'clock. So I'm happy to answer questions during the discussion. Premali?
Thank you, sir, for that speech. Now we will unmute all our listeners. So if you have any questions, you can direct it to the panel. All things Sarath, Lekamwasam sir is yet to join, but other three speakers are here. Sir, can I ask a question? And Thilak, Jayalath and Professor Senaka Rajapakse are also there. So even not being academic, even someone who is interested in doing PhD instead of doing, after doing MRCP or MD, that also a possibility of them to do it. Am I correct, sir?
I think it's a good thing if it can be done. The Ministry of Health doesn't give you leave for PhDs. That's one of the problems. But it can be worked around because there's no pay leave and various other things you can utilize. Very, very few health ministry people go for PhDs. There have been a few, I think. But it's a good thing, and certainly a master's or an MPhil is possible because it can be done part-time. Should be encouraged.
Yes, sir. That's what I thought as well. So we have a separate SR forum and another SR in a core group. If I just saw one chat box, somebody is asking about the membership, American College. You all can put that question there. So I will help you in that sense.
I think, Premali, there is a question about whether someone can get the membership, ACP membership, without board certification. I think that's what is. I think there is no problem. Senaka, I think you can correct me.
Yeah, I think you can apply as membership. The fellowship takes anyway, you have to be a member for a certain period. I think it's now 3 years, isn't it? 2 years.
Yeah.
But membership is possible because even the residents can be members in the US.
Yes.
Yeah, of course, you have to pay a fee. That's the only downside of it. But you can become a member, and it's advisable to be a member because the longer you are a member, the easier it is to apply for fellowship.
Fellowships.
And other the things that they consider us as, then that period they consider as early career physicians.
Yeah.
So they have opportunity to like presentations, abstract and things. But after 15 years, it will abolish. So better to apply early and be a part of them and can do certain things there.
I think they have to be nominated, isn't it, at this stage?
Yeah.
But there are so many fellows who are around. So I think Thilak all of us are in the have the fellowship, isn't it?
Yes, Senaka.
Mani is also a fellow, isn't it?
Yes, sir.
In fact, Senaka, we were planning to have a chapter, Sri Lankan chapter.
Yes, fine. But then they stopped the chapters for a period.
Yes. For some reasons, yeah. And also, I like to encourage these SRs. I think once you become members, ACP members, I think these annual sessions, ACP annual sessions, they are really good. I mean, they address all these common areas in internal medicine. So whenever you get a chance, I think now these more into online sessions, please join these ACP sessions. These sessions are held in April and May. So even this year, probably you can join. Very useful. I think Premali has been attending almost every year. Premali and Senaka also. I think you all can update on that. Very useful sessions, ACP.
This time it's virtual and physical as well.
Virtual, yes.
So in the absence of any questions, I would like to thank few people, and I would like to thank all 4 eminent speakers who spent their valuable time with us amidst their busy schedule. Thank you very much, sirs. And even though it is a 20-minute talk, it will definitely change someone's career and life. That was really interesting, thought-provoking talks. And then very big thank to our own president, Dr. Weerarathne, who is a pillar of strength for all of these behind us. And he's giving advices and encouraging us to do these kind of things, and our two secretaries. And I would like to thank It's Pharma for sponsoring this, and Mr. Dishan Fernando, who is doing this with the smooth running and webinar. Finally, to all of you, our future internists, without you, this won't be a success. And this particular webinar, particular talk, that has been there in my mind for a long time. And because we never had this kind of thing, this kind of motivational thing when we were juniors like y'all. So it is very much interesting, and to know all these eminent people here, they are talking to us, they say you can do this and that. And this Professor Thilak Weerarathne was talking about this developing on interest. So you will be master on whatever it is you do. And all these our speakers, and there are a lot of other academics and non-academic physicians. They are on their own specialist in their particular subject. If I tell, like Professor Sam Weerarathne, his interest in snake bites. Likewise, there are certain people who has developed interest in them. Then you all can do that. It is not a difficult task. So if you have a passion, you can do it. So I think it has been a very fruitful hour. Thank you very much, all of you. Have a good night.